Evening. Thank you for joining this virtual community lecture tonight, brought to you by Providence. Our focus this evening is going to be heart health. My name is Dr. Richard Wright. I'm a clinical cardiologist in Santa Monica. I previously wrote the guidelines on heart failure, and what I do is cardiovascular pharmacology. And tonight we have a very interesting speaker, my close friend and associate, Dr. Shephal Doshi, who's an electrophysiologist, and Dr. Doshi will be starting momentarily to give you an update on cardiology. But before we get started, I want to let everybody know that this is an hour-long presentation. We've left plenty of time at the end for your questions. Please use the Q&A box to type in your questions because we won't have the ability to listen to you from an audio perspective. And we're going to talk about general cardiology questions. If you have any heart-related questions, make sure you type them in the box. Well, we're not here and not able tonight to answer your personal medical questions. But if you have specific additional issues that we didn't address about general cardiology, you can email those questions to CA Lectures, CA like California Lectures, at providence.org, and we'll make sure we get back to you. Dr. Doshi and I are representing all 17 hospitals that Providence has in California. And although obviously we're only going to cover cardiology tonight, the Providence hospitals can care for all your medical needs. But specifically, we're tonight going to speak about cardiology because our 17 hospitals have world-renowned cardiologists performing the latest treatment options available for your cardiology needs. Tonight, the information provided is for general educational purposes. You should always consult your doctor and other healthcare providers if you have specific questions. So now it's my pleasure to introduce my associate, Dr. Shephal Doshi. Dr. Doshi practices in the field of cardiac electrophysiology, and that's the electrical system of the heart and arrhythmias. He's at Providence. He's a world-renowned expert in interventional therapies for arrhythmias. And these include atrial fibrillation, ventricular tachycardia, and other similar disorders of the heart rhythm. And although Shephal was born in Chicago, he was raised right here in Southern California, went to UC Riverside, and then received his electrophysiology training in Boston at the Mass General Hospital, where he was a clinical instructor at Harvard Medical School. Dr. Doshi remains active in leading-edge ablation research. He'll discuss what that means in terms of treating arrhythmias. Using different forms of energy, he'll show you how the electrical system of the heart can be altered so as hopefully to treat and prevent arrhythmias using energy to create small scars in the heart to block irregular electrical activity. Currently, Dr. Doshi is one of the national principal investigators and a leading expert in alternative therapies to anticoagulants, or as we commonly call them, blood thinners, in patients with atrial fibrillation. And some of his talk tonight will be focused on how we can potentially avoid the use of anticoagulants in individuals with atrial fibrillation, because of course we don't want anybody to have a stroke, and atrial fibrillation is one of the major potential causes of stroke. He was one of the leading experts and remains one of the leading experts for implantation of a device called the Watchman, which he will discuss this evening. But there are other approaches to atrial fibrillation, and he runs an atrial fibrillation center. He remains active in publishing. He's co-authored many articles in peer-reviewed journals, international journals, and he continues to travel internationally teaching cardiologists in Europe and South America, Asia, and across the United States how to use these life-saving technologies. And not only is he a great cardiac electrophysiologist, but he's a lifelong LA Lakers fan. Sorry about that, Doshi, this year. He loves beach sports, music, football, and his family. So, Shephal?
Thank you. Thank you very much, Dr. Wright. Thank you, first of all, to all of you that are attending. It's amazing how many people are on today, and we appreciate you taking time out of your schedule and your life after hours to hear this conversation. Rich's introduction was so long, it probably took away half of my talk time, but it was very eloquently done. The topic we're going to talk about, advancing cardiac care, a glimpse into the present and the future. It's a lot to cover. And, we have about a half an hour of me talking and then a lot of time to discuss these things. So some of these topics I may skim a little bit over the top just to introduce the concepts to you. We're going to talk about a lot of it is prevention. We're going to talk a little bit about that, but there's specific therapies that are designed to treat these arrhythmias. And some of these are very cutting edge. I'll discuss a few things that are not yet FDA approved. So I'll be very clear to tell you this is not approved. This is what's in research and in clinical trials. But hopefully at the end of it, in the end of this discussion, you'll have an understanding of what we here at Providence are able to provide in terms of leading edge cardiology, starting from prevention to management to even future therapy. So with that, I'm going to move to my first slide. So let's advance there. So if we look at, this topic, I think a lot of it is just trying to represent the scope of cardiovascular disease, how much prevalence there is of this disease. And I'm going to give you a few slides to talk about that, just to impart the importance of how relevant cardiovascular disease is. And then we're going to talk in two different categories, talk about some of the common conditions that involve the plumbing of the heart, valvular part of the heart, valve disease, and then switch over to some of the electrical sides of the heart. We think of the heart as having a plumbing system, an electrical system, and Dr. Wright's more of a general contractor, kind of manages all of that and prevents disease. And it's easy to break it down into these categories, but now we specialize in so many advanced therapies that we really need to focus on these things. So with that, if I just take you to the scope of cardiovascular disease, this was a very interesting and somewhat sobering slide when you look at the number of deaths by risk factor across the world. And this was only going back to a few years ago. This was a study that was published, and the citation is below. But if you look at the number of patients or number of people that die due to complications from high blood pressure, something that we treat so cavalier sometimes that, oh, my blood pressure is a little bit high, not a big deal. And then, something, a man-made cause of so much mortality, which is smoking. And Rich and I have the pleasure of practicing in Santa Monica, which has one of the lowest smoking rates in the country, less than 2%. But we recognize how relevant and important smoking is to all mortality and death, not just cardiovascular disease. So this just kind of gives you a scope of what we're going to be talking about. And if we look further into just smoking, right, and we look at the deaths attributed to smoking by country and what percentage of deaths, we used to be in the dark blue. And in North America, we're kind of shifting over to the lighter green side, so a lower percentage. There are still countries in Asia and in Eastern Europe, the stereotypical heavy chain smoking type places, and you can see what a large percentage of mortality and death comes from smoking alone. Now, in this slide, we're just looking at the percentage of adults that smoke as we look at some of the major countries. And if you look at where we were in 2000, clearly we're making progress. Right? The United States is in that green color, and you see that we were kind of in that 34, 35% range, and now we're kind of in the low 20s. It would be amazing to have it down to 2% from a disease standpoint, cardiovascular standpoint, and most Western countries are starting to come into that direction, but there's still a lot of work we need to do to educate and to help patients, kick the habit. If you go even a little bit further and you just look at the sales of cigarettes, per adult per day, and you look at back to the 1900s and where that, the US is in that green peak that you see at the very top. And, in the 1960s, we reached a peak. It was averaging 10 cigarettes per person per day were being sold in this country. And you look and see where we are now, we've cut that down in almost 2/3. So clearly there is an impact all over the world at reducing the number of patients and the amount of smoking that we do. Now, if we go into just simply the deaths, now we're going to forget on how many cigarettes are sold and how many people are smoking. It's still a large number in terms of the death rate attributable to smoking. And you look at the United States where we are in purple, the United Kingdom has actually passed us now, and they started at a much higher rate. And France, which stereotypically, has always been what we consider a high smoking country, has actually managed to lower their death rate from smoking at a much lower rate than what we have here in the United States. So if you can say what cardiovascular therapy can improve survival, and I'm not sure it's cardiovascular, but if we could just get people to number 1, stop smoking, number 2, stop smoking, all the way down to number 11, and stop smoking, that would probably have the biggest impact in the modern world in terms of improving cardiovascular survival and death. So while certainly we talk about what are the things we can do to change, a part of what we are dealt with is our genetics and the disease that we essentially develop and what we have. And a lot of it also relates to aging. So we can't reverse Father Time. And so we're going to need to talk about heart disease in general in the United States and talk about what's related to your genes and what's related to aging. So if you just look at heart disease, this is a map, a heat map is what we call it, of the United States. And the darker the color, the more there is present of whatever we're discussing. So this slide specifically is looking at death rates from heart disease in adults over the age of 35 by county. And it's going back not too long ago, up to 2019. And it's clear, if you look at this, where the concentrations of mortality are, heart disease is still the leading cause of death, okay, in men, women, people of most racial and ethnic groups in the United States. And if you think about this, one person dies every 34 seconds in the United States from cardiovascular disease. It's almost 700,000 people, died in 2020. So that's 1 in 5 deaths are from heart disease. And if you think about the impact it has on society, it's in the hundreds of billions of dollars. So clearly, heart disease, despite everything going on, is still the leading cause of death. And this is why it's important for us to really focus on this, the low-hanging fruit. And just to give you an example, this is something that I wanted to show you. So we practice in Los Angeles County, just as an example. So even in the area of LA County, where smoking is still generally less, if you look at the leading cause of death, what is number one? Coronary heart disease by far. Okay, if you look at the leading cause of premature death, again, it's coronary heart disease, way more than homicide, more than cancer, more than stroke, more than everything else, still number one. It's not a number one we want, but it's what we have to deal with. And if you look at the leading cause of death by ethnicity and race, it doesn't matter if you're white, Latino, Black, Asian, it's still coronary heart disease. And it's also the same situation when you look at the leading cause of premature death. So it's relevant in all of these scenarios. And again, this is painting the picture of the scope of the disease so we recognize how important it is. This is looking at by age group, okay? So if we're gonna look at patients over the age of 45 years old, that's the group that we wanna talk about, right? The patients that are getting older. And what is the primary cause of death? Whether you're over 50, over 60, over 70, it's still coronary heart disease. So hopefully I've kind of painted this picture that becomes more clear of how relevant heart disease is in terms of the overall numbers of death. And the things that you see on the slide. So on the right, you just see a bunch of different arteries. They could be in your neck, they could be in your leg, they could be in your heart. But what happens as we start developing disease, you see the arteries starting to get narrower and narrower and narrower. And some of the main risk factors that we see for heart disease, obviously you're familiar with, many of you recognize high blood pressure, high cholesterol, but the other medical conditions that are relevant in developing heart disease, smoking, we talked about, but diabetes, obesity, and a lot of these tie into each other. Unhealthy diet can lead to obesity, can lead to diabetes, which leads to physical inactivity. So many of these things are related. If we look at a heart attack, this is what everyone's worried about. Am I going to have a heart attack? There's one heart attack every 40 seconds in this country. And every year, over 800,000 people die of a heart attack. And what's scary is that 600,000 of them, this was their first heart attack, and they died on their first one. And 200,000 happen to have already had heart disease and a heart attack. And the other thing that's scary is that 1 in 5 of these are actually silent. People don't even recognize that they had a heart attack. And this is the scary part of it. It's one thing to have pain in your chest or pressure, but it's another thing to find out later that, oh, wow, you had a massive heart attack and now your heart is weak. So it's important for us to educate each other. And the concept of a heart attack is as follows here, what I'm showing you here. Plaque builds up in the arteries. Plaque is that stuff that you see in yellow, and it's building up inside as a person develops what we call heart disease, and the artery starts to get narrower and narrower and narrower. And it can completely shut down, or it can have a little crack, and suddenly the contents come out and you form a blood clot, and then you have a heart attack. And so this is the mechanism of how people get blockages in their arteries, plumbing blockages, which then lead to a heart attack. And the other frightening thing I talked about, or that we should talk about, is 2 out of 10. So there's 1 out of 5 are in adults under the age of 65. And so I'm sure no one on this call is over the age of 40, but it's still relevant as our population and our diets change and our diseases change. We're seeing heart attacks in younger and younger people. And so what is a heart attack? Is it just about getting older? Can we prevent it? Can we improve our risk factors? What about genetics? Is there medical therapy to reduce risk? These are all important questions And also, if you have a heart attack and we put on medical therapy, will it reduce your risk for a second one? And what can we do about it? In this video here that you're going to see is an animation that shows you what we do when we open up a blockage. Oftentimes, we now just go from the wrist. Sometimes we go from the groin area, and we can advance a wire and inject some dye into the artery like you see there. If we see a narrowing or a blockage, we can calculate how severe the blockage is and decide whether it's important and whether we have to open the blockage before it shuts down. And the way we do it, when you look at it on this animation, it looks relatively simple. We put a wire across the blockage. Over the wire, we advance a balloon. The balloon is then inflated, and it kind of smushes the plaque to the edges of the artery and opens the artery. And, what we used to do going back 30, 40 years ago, we would just have a balloon and we would just open it, and the artery would look better. And then that would be the end of the day, and we would go home, send the patient home. And later on, we found out that the arteries build the plaque back up and the narrowing comes back. And a large portion of our patients, when they just had what this is called as angioplasty, a balloon angioplasty, it would come back. So since then, we've developed the concept of having a stent. This is a kind of a metal shaped funnel that sits on the balloon, and we open it up with a balloon. And what the stent does is actually opens up the artery better than the balloon. But what the stent is able to do is keep the artery open at a much higher rate than what we could have done with simply the balloon itself. And so this is kind of the current treatment for someone who has symptoms in their chest that are severe or a lot of heart at risk or present with a heart attack. The other questions on the left are relevant and clearly things that should be discussed with your treating physician. So now let's talk about probably one of the more preventable diseases in the United States and the world is high blood pressure and hypertension. And just to give people a perspective, what is high blood pressure? It's the pressure in the blood as it's pushing through the walls of your arteries. The arteries are the tubes that carry the blood from your heart to the other parts of the body, and it's normal for blood pressure to go up and down throughout the day. But for many patients, it just stays elevated at too high of a level that it can cause damage, especially if it stays there for a long time. And so hypertension, which is also known as blood pressure, is when blood pressure is higher than normal. Okay. And so if we look at that and we think about what is hypertension, there's a lot of confusion among patients about what is the number we're trying to treat. And sometimes we adjust a number depending on the patient's risk factors, depending on their age. But classic teaching, when you think about hypertension, is when your systolic or the top number starts getting into the 130s. And then when your bottom number starts getting into the mid to high 80s and even 90. And so this is what we consider hypertension. There's different stages, that's not so relevant. But if you're consistently having blood pressures when you're relaxed, when you're not stressed out, and your blood pressure is 150 over 90 consistently, these are things that are very important to treat because as I'm going to show you, it's going to have a pretty big effect on you having heart disease, death, and even stroke. And so let's look at the map for hypertension. And remember, I showed you the map of cardiac death, right? Death from coronary heart disease or heart disease. And hypertension map looks very similar, doesn't it? The regions that are bright red are very similar. The regions that have high blood pressure in this kind of amount tend to be the regions that have higher mortality, higher death. And it seems to cluster in that tobacco belt area, right? Which is in that southeast, which is also related. So all this plays a role. A greater percentage of men, 50%, have high blood pressure compared to women. And high blood pressure is more common in non-Hispanic Black adults compared to non-Hispanic white adults or Asian adults or just Hispanic adults. So these are just things to remember, but it's still a very important disease to treat. And as you start seeing these maps, you'll see more and more of them are looking similar. But here's the interesting thing about hypertension. I mean, nearly half of the adults in the United States, almost 50%, that's 120 million people have high blood pressure, defined by a blood pressure greater than 130 for the top number, what we call systolic, or greater than 80 for the bottom number. So that's almost 50% of the patients. And only 1 out of 4 adults that have high blood pressure, okay, so of the 120 million that have it, only 1 out of 4 actually have it under control. So 3 out of 4, even though they're being treated, don't have it under control, or many of them may just not choose to have it treated. So it's really important fact to understand that we as a society are not doing a great job controlling blood pressure. Is it the physicians? Is it the patients? Is it the communication? What is it? We have to figure that out. But I think we all need to understand how important it is to treat high blood pressure and what's affected by it. And so what risk factors can we do as patients, and what can we do as clinicians and physicians to educate, to say this might help? And I think one of the biggest things that's overlooked is weight loss. You know, anything that puts less demand on your body can reduce blood pressure. So weight loss is huge. Dietary changes can really make a big impact. But the one thing that should not be forgotten is that medications can work very well. And what we used to do in the old days, which is come back in 6 months, try to lose 5 pounds, we say, you know what, we're going to start you on treatment now. As you lose weight and your blood pressure comes down, we can take it away. The other things that we should talk about on another day is managing sleep and managing stress. But in reality, this is the real world. Stress is always around us, and it seems to be around us even more these last 4 or 5 years. Sleep management's a huge issue. And in the end of the day, we're going to need to figure out a therapy that we'll be providing, and therapies that we will be providing to patients to help them, and everything together. And what I'm going to show you on the right is, again, something that is not FDA approved. This is a novel therapy, a novel concept that is in clinical trials. And so this is a trial that we're doing in our institution. And one of the few places in the world that, is having these studies is to look at a way that we can do a procedure to reduce your blood pressure. And this procedure, which is under clinical trials, called renal denervation, there's a lot of data to suggest that signals that come from the kidneys cause an elevation in blood pressure, because your body signals the kidneys release these hormones, and then your blood pressure goes up. So the concept is what if we could put a catheter into the artery, and we can ablate or destroy those nerves without damaging the artery wall that are sending signals to the kidney to affect blood pressure. And many of the early preliminary data of this recent technology, and this technology uses ultrasound, has shown a pretty dramatic impact in patients. Now, again, this is under clinical trial. We need a lot of patients to be studied to know if this works. But if this works, and we're able to treat patients with a simple outpatient procedure and have a huge impact on 110 million people who have hypertension, along with medications, along with weight loss and dietary changes, this could have potentially one of the biggest impacts if the therapy is successful. So what you're seeing is a balloon delivering ultrasound, and then those nerves that are outside the heart are no longer connected. Outside the kidneys are no longer connected to the kidneys. And we would do this in both sides: advance a wire, deploy a balloon, emit ultrasound. So the ultrasound doesn't damage the artery, but only affects those nerves on the outside. And then what happens at the end of the day, after you've done the procedure, even though the brain is signaling release of those hormones in blue, it never gets to the kidney. So you see the before on the left and the after on the right. And so again, I just want to make sure everyone understands this is a clinical trial. We still need a lot of data. It's going to take us a few years to figure this out. But I do have a lot of hope that we'll be able to provide some therapy to help manage this killer of hypertension. So we talked about that. I think one of the other things that's important to talk about, a place we've made some amazing strides, is managing of heart valve disease. And many of this is just related to aging. If you look at the age of patients and you look at them developing valve disease, which is in red is all valves, and the really interesting one that has really been proven to be a huge impact is aortic valve disease in blue. You can see that 1 out of 8 patients are over 75. So that means if you're over 75, 1 out of 8 will have some type of aortic stenosis. So this is something that happens with aging. And to just paint a bigger picture on this, once you get symptoms, and I'll show you what's happening here of this valve, and the valve doesn't open, you see that waterfall, you see the curve falling down. Many patients don't survive more than a few years. And so it's important we have therapies for it. And the therapy that used to happen, you'd have to have open heart surgery and get the valve surgically put in and your old valve taken out. You can imagine in your 70s, 80s, and 90s, the thought of having open heart surgery, many patients just wouldn't want to do it, or were too high risk to do it. And so what's happened since then over the last 5 to 10 years? And if you look at this image on the top left, that's a normal valve. That's a normal aortic valve as it opens. All the blood in your body from your heart goes through that hole to the rest of your organs. So it's really important. And look right below it when you have a very diseased valve. That valve is full of calcium. The patient's gotten older. It was just not even a genetic thing. They're in the mid to late 80s. Now the valve's not opening, so we're going to have to do open heart surgery, right? That's what we would do. But if you look at the animation on the top right, we now have a way to do this procedure through a catheter without doing open heart surgery. And it's called transcatheter aortic valve replacement. So if you look in the bottom image, we're using a balloon to put a new valve and open up that valve and let the new valve take over. So this has really revolutionized how we manage valvular heart disease. And this is being done at many of our ministry hospitals here at Providence, and has been kind of a big step forward, especially for the typical patient who is older, who has many other forms of disease that makes them high risk for open heart surgery. So as we've talked about the plumbing and not spending too much time just in one section, I just want to briefly just go over the electrical issues of the heart in the next few minutes and just kind of come for a full circle. So I think the important electrical issue to talk about is atrial fibrillation. Atrial fibrillation is the most common heart arrhythmia. 12 million people in the United States will have atrial fibrillation, and it's 1 in 10 at the age of 75. And so AFib is a disease of aging. When people reach 70 or 75, it becomes very common. And so what's the relevance of this? On the left, you see the heart squeezing normally in that little animation. On the right, the chambers are disorganized. And what happens when it disorganizes, it can cause the heart to beat very irregularly, which can cause patients to feel symptoms and also increase the risk of stroke. So many patients are very symptomatic. They feel fatigue, they feel short of breath, they feel their heart palpitating and racing, they feel dizzy, they feel anxiety. And some people can even develop a weak heart when they have such disorganized activity. And if you look at the map of atrial fibrillation, doesn't that look similar? Look at the incidence of atrial fibrillation and all over the country. But you also see clusters where you just see older people, right? And many of these patients do get hospitalized. So what can we do for these patients who have atrial fibrillation? What are our options? We can certainly give people pills to kind of convert their heart rhythm. They work less than 50% per year, but that's all we had before. But since 2004, we've developed new technology to actually fix the atrial fibrillation. So the pills might be a nice therapy when we had no other options. We can do this procedure that Rich was talking about called ablation, where we actually go into the heart and rewire the heart electrically by putting these catheters in. We can use heat, we can use cold, and we can use some even novel new technology, which is not yet FDA approved in the United States, but is taking Europe by storm. And I want to show you an animation of an ablation. The patients are asleep. This is done as an outpatient. It's not a surgery. You go home in a few hours. We insert a catheter that goes into your heart. And this catheter is advanced right into one of the chambers called the atrium. And that's where atrial fibrillation comes from. And we go into the left atrium. And what we do is we insert the special catheter. And we know that the AFib comes from these veins. So we can move this catheter around and actually burn around the veins. Okay, so we're not closing the veins, we're not blocking the veins, but what we're doing is we're creating electrical block, building a fence. So the short circuits from inside the vein cannot come out. And this has a very high success rate. And one of the things we're proud of at Providence, we have an initiative to organize and be consistent with our programs that we have now the ability, and we've been sending patients home the same day from this procedure in almost 80% of patients, if not a little more. So the technology has improved, our understanding and our technique has improved to the point that we can send most of these patients home the same day. This is a similar concept using cold, but this animation will help you understand. You see the short circuits coming from inside the vein. We put the balloon on the outside. This is a different way. This is using freezing instead of heating. And what happens is the balloon freezes, and it's like burning a wart with liquid nitrogen that's so cold that it burns the atrial cells so that any electricity coming from the inside is blocked inside, just like we had done in the other animation. So these are some of the ways that we can do that. Now that's great for fixing how you feel with atrial fibrillation, making you feel better. Many patients are good candidates. But the biggest issue with AFib is what is the thing that causes the most disability, death, and disease, and that is stroke. And atrial fibrillation is responsible for 1 in every 4 strokes, okay? And it depends on the patient population. If you don't have a lot of risk factors, it may be 1 in 7. If you have a lot of risk factors, it may be 1 in 3. So we have to really look at the individual patient, but no matter what kind of patient you are, your risk of stroke goes up 5 times when you have this irregular heartbeat. And many of our patients are not able to take blood thinners, which is the standard therapy for these patients. So what do we do in these patients who cannot take blood thinners? One of the things that we've been very proud of at Providence in our institution is having worked on this therapy called left atrial appendage closure. This appendage is a pouch that we're all born with, and this is where the clots form. And what we found out is that if we're able to actually plug this clot and put a device that seals off the pouch, then many patients are able to get off of the blood thinners. And what you're seeing on the top is having a catheter in the pouch, and we're going to deploy a device. The 2 devices you'll see are the 2 that are FDA approved. On the top is the Watchman device, and it simply seals off the pouch. And after a number of months, patients are able to get off the blood thinners. And on the bottom view, you just see the concept. We go up with the catheter, again, into the atrium, and you see one type of device on the top called a Watchman, and on the bottom, you see a device called the amulet. And this device also closes off the pouch. They have little hooks that hold it into place. But our studies have shown that for patients who are not able to tolerate blood thinners, this can dramatically reduce the risk of stroke, where they're only left with taking a baby aspirin. And finally, I just want to show you one animation about something you're probably familiar with, pacemakers. You know, pacemakers have always been considered a surgery. You take a scalpel, you make an incision in the chest, and this is what a pacemaker looks like. It's about the size of a silver dollar. It has wires that go into the heart, and it has its own inherent risk, but this hasn't changed in almost 50 years. And I just want to show you in this animation how pacemakers are placed typically, right? So we make an incision, you're often under anesthesia, you're in the operating room, and we have to do surgery to put the pacemaker in right under the vein, and the pacemaker sits there. And now you have 2 wires that go backwards into the heart. And it's an excellent therapy, very low risk, treats a lot of our patients, and the batteries can last for over a decade. But as we try to innovate and create, better concepts in terms of technology, can we do something better? And now you see the old pacemaker, and you see the vitamin capsule on the right, and the newer type of pacemaker. These are called leadless pacemakers. They have no lead. The pacemaker is about the size, of a vitamin capsule. And these don't require surgery. So we can go in from the vein, insert these novel pacemakers, and there's different types. There's a couple of different brands out there, and that's not so important. It's the concept that we can go into the heart without surgery, put a device like this, have it attached to the heart muscle, make sure the device is in a good position, and then able to program it, and then take the device out. So we can always still program the device even after we're done, but the procedure can be done in 30 minutes without requiring surgery, and patients can go home the same day and have a pacemaker that works with MRIs and is also giving them 10 years of battery or more. So all these technologies, some of them are being used today, but where we see these in the future, it's quite impressive, where our whole population may be very, very different as we go 10 or 15 years down the road. And so in conclusion, from my standpoint, and thank you for giving me this opportunity to kind of discuss this, while cardiovascular disease is frightening, and maybe I frightened you by showing you all those maps of where disease is and how patients are dying, we have a lot of opportunity here to make an impact. And with close follow-up with your treating physicians and discussing the simple things like how to manage blood pressure, and if we can't manage it right, maybe we look at getting you in a clinical trial or looking at novel therapies. These are the therapies we have available for us. And if you follow up closely with your physicians, it's not just about improving your quality of life, which is obviously very important, but we also want to improve your longevity as long as your quality of life is good. So as we continue to innovate, these novel therapies will continue to allow us to treat our patients effectively. And with that, I would like to thank the folks at Providence, thank all of you for attending, thank my colleague, Richard Wright, and I think we're going to move forward to a lot of questions. And I didn't touch on a lot of things just for the sake of time, but wanted to introduce you to prevention, current management, and where we are going to in the future. So thank you.
Well, thank you, Dr. Doshi, for that fascinating presentation. I want to invite everybody who's listening to, if you have questions, type them into the Q&A box, and we'll try to get to as many of them as you can. Prior to that, though, we want to ask you a question. And we want to poll you about this. So please answer the poll so that we can improve our presentations in the future. And this is the poll. You know, did we meet your expectations? Do you feel confident that your heart health can be serviced at one of the Providence hospitals in California? And also, which was the most informative part of the presentation? And while you're answering those questions, I'm going to ask Dr. Doshi to answer some of the questions that you have posed to us. So Shephal, somebody asked, if you've had atrial fibrillation once, does that mean you're going to have it again? And does that mean you're going to be obligated to either consider a procedure like you're talking about or consider lifetime therapy with an anticoagulant?
Yeah, you know, when I try to explain atrial fibrillation, I try to explain it with the concept. It's kind of like that fluorescent light bulb in your kitchen that starts flickering. The first time it flickers, maybe the first time or it may have happened before, but you notice it and you're not going to rush to the hardware store if it's a few seconds. But you know, eventually, if you don't change that light bulb, the flickering episodes will start becoming more frequent and last longer. And that's very similar to atrial fibrillation, unless it's one of those cases where you're under immense stress, physical, personal, surgery, something going on. It's possible that you may not have another one, but most of our patients, once they have some, eventually over time, the amount of arrhythmia will increase.
So do you think people should go out and get an Apple Watch or something to try to demonstrate if they're having funny feelings of rhythm in their chest? What do you recommend for people to find out if they have atrial fibrillation?
You know, and I appreciate, you know, the self-motivated patients who go out and get their own wearable Apple Watch or now there are other watches that get EKGs. But I think first start with seeing your healthcare provider. If you're feeling your heart is doing something funny, and you know, the human heart beats 100,000 times a day. So you think about that. And obviously we don't feel every heartbeat or we'd go crazy, right? And so suddenly if you're aware of your heartbeat that you weren't before, or something feels off or different, and you're over the age of 65, and definitely if you're over the age of 75, I would first recommend calling your healthcare provider and getting checked out. And it may involve getting a monitor placed in their office, something with higher resolution than perhaps an Apple Watch. But if you want to take your own initiative and get an Apple Watch or another kind of watch, Garmin, there's different brands that do it. You certainly can. Just be mindful. Those things are not medical grade devices necessarily, and they can miss things. And you don't want to be your own physician. So I would definitely encourage you to see your healthcare provider.
Somebody asks, how can they find out whether they have heart disease? In other words, let's not focus for the moment on atrial fibrillation, but the more common kind of heart disease that you started your presentation with, of having hardening of the arteries or atherosclerosis. How does somebody, not a 20-year-old, but let's say a 50 or 60-year-old, how could they find out whether they have the beginnings of that problem?
So, you know, there are a lot of things that we can do, even from general practitioners to cardiologists, that can screen for heart disease. And it really depends on your age, your risk factors, other medical diseases you have, like high blood pressure, smoking, your family history, your cholesterol levels. And it's too much for you as a patient to think about all this. So I want to just simplify it. I think if you're at a certain age and you can pick that number, and Rich, I'd love to get your input because you're the preventative cardiologist here. You know, at some point you're going to see your healthcare provider and they should be, and then you should encourage them, you know, is it time for me to get screened? You know, I may have, if you have symptoms, it might be done sooner. If you have a family history. At what age do you think, Rich, would you kind of encourage people to be more proactive about it? Or is there an age?
Well, there's definitely age. As you said, this disease does not appear in 12-year-olds, right? So it's clearly associated with age, no question about it. We know it's a disease that's been around for centuries, in fact, for thousands of years, because if you do x-rays of Egyptian mummies or mummies in other parts of the world, you'll see that they actually had atherosclerosis and hardening of the arteries even 3,000 or 4,000 years ago. So this is a disease which has been manifest for thousands of years. It's only recently that we've had appropriate treatments for it. So to answer the question of who should be screened, if you want to use that term, it depends on your age, but also your personal health history. If you've had family members who've had premature coronary events, if you yourself have had diabetes, if you have had longstanding high blood pressure, if your cholesterol levels are egregiously high, these all make you personally more likely to have the biggest cardiac problem, which is atherosclerosis. That's the fundamental reason for heart attacks and for many strokes, not all strokes, as Dr. Doshi says. So currently there are the traditional as Dr. Doshi mentioned, the risk factors, a term that was coined many years ago. But the things that everybody knows about, high blood pressure, high cholesterol, smoking, diabetes, obesity, sedentary lifestyle. And the more of those you have, the more likely you are to develop the disease. But what has emerged in the last couple of decades is that if you have calcium demonstrable in your artery, it means you have the plaque that Dr. Doshi showed you. The plaque starts as a soft deposit of cholesterol, but eventually it ends up being a hardened part of the artery due to the healing responses of the body. And you can detect this by X-ray. So one way is to discuss with your healthcare provider whether a coronary calcium CT scan, for example, which is a very simple, easy test to do, whether that might be something that you should have to determine whether you have heart disease or not. Because if you do, then you're more likely to benefit from cholesterol lowering and from losing the weight that you've been trying to lose for so many years, and maybe getting off our rear ends and doing some more exercise. So that's what screening is really looking at, these risk factors, knowing what your blood pressure and your cholesterol values are, and perhaps talking to your healthcare provider about, do I have calcium in my arteries? Because that is a sure sign of atherosclerosis. Somebody asked, what's the relationship between rhythm disturbances and heart function? And they specifically use the word heart failure and cardiomyopathy. Would you like to comment about that?
Yeah, absolutely. So when we talk about heart function, we always focus, or we mostly focus on the pumping of the heart. And the heart has two chambers. It has an upper chamber, which is more like administration, called the atrium. And you got the workers down at the bottom, which is the muscle called the ventricle. And when we talk about congestive heart failure and we talk about weak heart muscle, we're really focusing on the pump of the heart. The workers, they become weak and they can't meet the demands that the body needs. Now, some arrhythmias, some electrical short circuits can make the heart muscle weak in the pumping chamber. And there are a lot of different scenarios that could happen. Some people can have atrial fibrillation and their pumping function is normal. Some people can have atrial fibrillation, the pumping function is weak. Some people can have different arrhythmias that can make the pumping function weak. If their heart's going too fast, this can happen. Some people can develop electrical problems in their heart that makes their heart work efficiently, and it can become weak. So there's a lot of things that can tie in a rhythm disturbance to a weak heart, but that's not always the case. Sometimes it happens even with a normal rhythm, and Dr. Wright is a heart failure specialist who sees those, and I think it's very crucial if you start developing symptoms that could represent heart failure. And Rich, I think maybe it'd be nice if you could just review a few of the symptoms for patients to at least seek out their physician and healthcare provider to at least get assessed.
Sure. So if you're talking about the heart not doing its job, and as Dr. Doshi says, the fundamental job of the heart is to pump blood. If it's not pumping an adequate quantity of blood or not adequate pressure of blood, then the body senses that there's a problem, and that then develops into a syndrome we call heart failure. And when heart failure develops, the kidney is told to hang on to extra water. So one of the common findings that people have, and whether this is due to heart failure because the muscle's struggling, or as Dr. Doshi said, because the heart has been beating too fast for too long, and much like your car, you can't have your car go at 14,000 RPM and have the car last. So if the heart's beating too fast for too long, or other reasons to have it fail, you may notice that your breathing is short when you're doing activity. You may notice water retention usually manifest in the feet and ankles, and you have swollen ankles. Maybe your exercise capacity isn't very good. You start avoiding activities. You take the elevator instead of the stairs. And a lot of you may think this is just aging, but in fact, it may be a signal that your heart is not performing adequately. And there are many ways to assess this. And again, this is something that you can't self-assess, but is easily able to be measured with modern technologies and blood tests and things like that. Shephal, somebody asked whether is heart disease reversible? Let's sort of take the broadest 35,000.
Yeah, that's a great question. And just to kind of go back a little bit, heart disease is made up of 1,000 different categories, maybe not 1,000, but enough different categories, there's different causes, right? And I was showing you the scope of disease, and we talked about all the things in the plumbing aspect. Those things are electrical, some things involving the valve. In some scenarios, if you fix the problem that caused the heart disease or caused a weak heart, the heart can go back to a normal function. So when you have a very narrow and stenotic valve and it's causing too much strain on your heart and your heart gets weak, you fix that valve and the heart can become near normal again. And just like you have an arrhythmia and your heart's been beating too fast for too long, and we do an ablation and we fix it, and the heart rhythm goes back to normal rate, suddenly the heart function can come back. There's a lot of medications that Dr. Wright has, up his sleeve that he can give patients, and many of these reverse some of these effects of heart disease. But if you've been unhealthy and you've been smoking for 40 years and you have diabetes, and suddenly you have multiple blockages and all over your heart, and you need to have a procedure done, bypass or a stent, those things can be life-saving, but you can't necessarily reverse the disease that you form. So I think that's a very loaded question, a great question. And some parts of heart disease can be reversed. Other parts that are related to aging and that are related to other things don't necessarily get reversed when we apply treatment.
Yeah, I would agree with that. I mean, if you look at for example, if your heart is struggling, then unburdening the heart and making the heart's job a little easier, and laying the groundwork with medicines and things, maybe making the energetics of the heart better, et cetera. Can we improve the heart's function? Yeah, we can. In most cases, that's the case. But we can't reverse aging, right? So there are going to be changes that are manifest, be that causing arrhythmias or heart failure, which we can't change. With regards to the arteries, the common kind of atherosclerosis, the goal really is stabilization. There is evidence of a little bit of regression, meaning, can you make a plaque somewhat smaller? Yes. Can we make the plaques go back to how our arteries looked when we were in college? No, we can't do that. Just like we can't.
Not yet. Maybe
yet.
one day we'll
Maybe.
be able.
Yeah. Well, there are lots of therapies. I mean, if you look at the vaccines that we have for COVID, right? That's a brand new technology, and that similar technology is now being used in cardiology to alter the genetic expression in certain types of cardiac diseases. So we're at the cusp of a huge explosion in so-called biologics and even altering genetics. So stay tuned. That'll be coming in the next 5 to 10 years. Somebody asked, how slow can the heart be before you get nervous and are talking about a pacemaker?
That's a great question. And, for years, we would come up with these criteria as if we went up, and came down with the 10 commandments, and one commandment said, if your heart rate falls below this number, you need a pacemaker. And that's changed a lot in the last 10 to 15 years. We recognize that obviously there's some absolutes. If someone's heart rate is 15 beats a minute and they don't feel dizzy, we're still not okay with that. But what really drives our decision for most patients for pacemakers are the symptoms. So if you can't function, and that's because your heart rate doesn't go up, or it only gets to a certain level, that's one of the primary reasons we put in pacemakers. And for one person, it might be 40. For one person, it may be 60. I had an 85-year-old patient who had a heart rate of 35. And he said to me, he goes, doctor, I was an Olympic athlete. My heart rate's always been slow. I said, yeah, but you were an Olympic athlete in 1941, and now you're 85, you're not as efficient as you were, and your heart's not the same. So it does vary. And the other scenario when we put in pacemakers are when we see impending doom. Sometimes we can see on an EKG that you're at a chance or you're at a risk that the electrical system of the heart is going to fail and you won't have a pulse. And we see certain findings on the EKG that we say, look, I know you feel okay, but for you, we can't wait for your symptoms because you could basically have no pulse, and that could be really bad news. So in a subset of patients, we'll put in pacemakers, preventing them from having a catastrophic event. But in the majority of patients, it's really those patients that don't feel good, that are getting dizzy and lightheaded, whatever the rate is. Obviously, if it's 80, that's a different story. But if it's 45 and they feel like they're passing out, or 30, those are both indications, and just depends on the patient's symptoms.
Somebody asked, aspirin, they've heard aspirin is a blood thinner. How come aspirin isn't used for atrial fibrillation?
Smart person. Clearly, we did try that. And aspirin is not a blood thinner. Aspirin makes the blood, so if we want to use colloquial terms like that, aspirin makes the blood less sticky. It affects the platelets, which are in the blood, which are part of the process that forms a clot, but they really stick to the bleeding areas, versus an anticoagulant, which we often use the term blood thinner. And it's a different mechanism because it doesn't allow clots to form in the blood. And so aspirin generally in the Western world causes less bleeding than the anticoagulants do. And aspirin is very useful in certain forms of heart disease that are in the arteries. So when you get a stent, when you have blockages, aspirin helps those blood vessels stay open by promoting the little cells to crossing through, right? And so aspirin is really good for coronary artery disease, for vascular disease, because atrial fibrillation, or clots that form in the heart, wherever they form in the heart, are large areas, like the appendage, where I showed the Watchman device being deployed, for example, or inside the muscle. Those are large clots, and they actually need an anticoagulant. Aspirin's not strong enough to dissolve those clots or prevent stroke. It had a minor impact in stroke benefit. The majority of benefit is from actual blood thinners in the patients who can take them. So if you have atrial fibrillation, your clinician will actually prescribe an anticoagulant or a blood thinner. But if you had a stent or a heart attack, you're typically prescribed aspirin.
One more question about AFib. Is all AFib the same? And if somebody has 2 minutes of atrial fibrillation versus 20 minutes versus 5 days, do you treat them differently?
Yeah, that's something that we're still trying to understand. So when we think of atrial fibrillation, you're either having AFib or not. And we classify it in 3 categories. Do you have it some of the time? Do you have it most of the time? Or are you in it all of the time? And we can't convert you. And those are the definitions of AFib: paroxysmal, persistent, permanent. So that's how we classify AFib. Now, in terms of the patients that are only having some of the time AFib, we still don't know, is there a magic number where they have enough AFib that they get a blood clot or a stroke? Some studies show that even having 2 minutes of AFib is similar to having 2 hours of AFib. And some studies show that it doesn't matter when you have the 2 minutes of AFib, you could have a stroke 2 weeks after that, or even before that. So we don't really understand, but we know that AFib increases the risk of stroke. We don't know exactly how much is needed on a given patient, but since stroke is so catastrophic and has the highest rate of disability and a high rate of mortality, the problem with strokes is many patients say that you don't die. You're still alive and half your body's paralyzed. We want to do everything we can to reduce that risk. And there's no doubt that whether you have 5 minutes or 10 minutes or an hour, if you're 80 years old and you have high blood pressure and you're high risk for a stroke, we should treat you the same, and that's put you on a blood thinner or some therapy to reduce the risk of stroke.
So here's a question I know you don't have any personal experience with, but is erectile dysfunction associated with heart disease?
Rich, since you treat preventative medicine and are probably closer to this question than I am, I'm going to let you answer that.
Yeah, so the answer is yes, there is. And we're not absolutely sure why that's the case. And some have speculated it's just due to poor blood flow, which of course is needed to achieve an erection. But there is clearly a connection. And if somebody has erectile dysfunction, particularly at an early age, it is a sign that they could in fact have heart disease, perhaps of which they are unaware.
Yeah, I think, go ahead.
Yeah, there's another question. You brought up this concept of sleep apnea early in your talk.
Yeah.
What is the connection, if there is one, between sleep apnea and heart disease in the broadest sense?
Yeah, so if you take a step back and think about what's happening with sleep apnea in concept, what's happening is that at night or when you're trying to sleep, there are many periods where you don't breathe correctly. And when you don't breathe correctly, you're not getting enough oxygen into your body. And when that doesn't get into your body, it doesn't get to your organs. So when you have sleep apnea, all of your organs in your body are oxygen deprived. Your brain, your lungs, your heart, your kidneys, it affects everything. And it has been so underdiagnosed and undertreated, primarily because there haven't been great treatment therapy options in the past. That's improved a lot. And also lifestyle changes, weight loss, surgery, there are a lot of options. So when you think about any organ in your body, especially the heart, being oxygen deprived day after day after day, that's going to have an impact on the muscle and the cells of the heart. It's going to leave them more prone to short circuit, more prone to get weak and have other issues related to that. So that's kind of the high level view of how sleep apnea affects your organs and your heart. But Rich, if I could make one comment, you talked that we had the question before this. I think many patients don't realize that arteries are arteries are arteries. So you see a patient, they have a little plaque in their carotid artery because they had a scan. And they say, well, I don't feel bad. It's only a certain percentage. I don't know if I want therapy. And I have to remind them, whether it's an artery in your neck, whether it's erectile dysfunction, whether it's an artery somewhere else, you have the same arteries in your heart, and those things are also getting affected. So vascular disease can involve any of the arteries, but then would affect many of them at the same time.
And what would you recommend with regards to people's lifestyle, their diet, their exercise, their weight, short of medicines, which we are strong believers in? What can a person do on their own to reduce the risk of these cardiac issues?
Lifestyle really is more common sense than anything else. Things, first of all, that make you happy. Things that in turn reduces stress. So, to give you an example, they did a clinical trial taking patients who have heart arrhythmia, like atrial fib, and they were all on the same medications. They all had the same therapies, and half of them were randomized to having meditation yoga versus the other groups. They were on the same medicines, everything else the same. And the group that did meditation yoga had a 30% reduction in episodes, which was pretty much what the medications could do, was 30%. So there's no question that stress, which is a part of life, impacts this. But all of this are tied together. So if you exercise more, you lose weight more, you feel less stressed, you feel more energized, you have a healthier diet. All of these things are kind of tied in together. But most of this is pretty commonsensical. But you can't blame everything on lifestyle either. Some of these things are just genetic. When you were born, to imagine your mother put 1,000 light bulbs from Costco, and no offense to anyone working at Costco, I use that as an example, but you may have gotten a batch that's just as short-circuiting. So we can't, oftentimes patients just say, oh, it's just stress. I don't want to take any medicines, have no therapy. I'm just going to change everything. So I think it's important to keep that in mind, but all of these things are related.
Yeah, and I would agree with that. I think if you had to say, which thing can you do that would lower your risk, it's actually exercise. And I realize many of you don't want to exercise, and you don't have to run marathons. What you need to do is not be sedentary. The big benefit is the difference between being active and being sedentary. If you're active, you're going to lower your risk of all these things we're talking about, be it atrial fibrillation, hypertension, obesity, diabetes, coronary disease, heart failure. All those things are better if you're physically active. So start taking the stairs instead of the escalator and the elevators. And we need to get off our rears and do more, is what I'll say.
Even 30 minutes of brisk walking, 4 or 5 times a week will make a huge impact. Just going out there, going for a brisk walk.
Well, we're down to our last minute, and I just want to thank everybody for attending this lecture. I wish we had more time. We have literally hundreds of questions in the Q&A box, and I want to thank everybody who submitted a question, and particularly thank Dr. Doshi for spending the time with us tonight. We will be sending a recording of this presentation to all of the people who've attended, and it will also be posted on our Facebook page and our YouTube channel, which you can access by typing Providence in the search bar of YouTube. So no matter which of the 17 Providence hospitals you're familiar with, just be aware that this will be available to you on the internet, and you can find a physician if you want to schedule an appointment with any of the Providence hospitals by phoning 855-415-8191. Or you can reach us at providence.org, 855-415-8191, or providence.org. Thank you again, and have a very good evening.
Thank you.